Hey everybody, it's Dr. David, the ear, nose and throat doctor. I am going to talk about a condition called upper airways resistance syndrome. Now, this is an interesting topic because to understand the condition, you need to appreciate the history that led to the creation of the term. So let's do a little history lesson. When I was a boy, which I'd like to say wasn't too long ago, there was an emerging awareness that a disproportionate number of people were having motor vehicle accidents in the context of being tired. And when that was identified, the people started looking as to why these people were tired, and they stumbled across the fact that these people were snoring a lot. And that progressed to then an appreciation that these people were not just snoring a lot, but they're having moments where their bed partner was witnessing them stopping breathing at night, which we call an apnea. So that's how the story started. So we had people driving, crashing their cars, they're having these accidents, and snoring and stopping breathing. So through the process of evolution of technology, we were able to do these things called sleep studies. And as time has gone by, we've learned and evolved about what we can measure and what those measurements can be interpreted as. And broadly speaking, what we ended up with a condition called obstructive sleep apnea and obstructive sleep apnea syndrome. Now, obstructive sleep apnea just means that you stop breathing at night, in essence. I'm going to get a little bit more pedantic in a sec, but just keep it simple. And obstructive sleep apnea syndrome means you stop breathing at night and you have symptoms. And one of the big symptoms, obviously, with people having the car accidents was the fact that they were tired. So tiredness was linked to not breathing and sleeping properly. What they then started to recognise as patterns in a broad sense was, generally speaking, these people that were snoring and stopping breathing were, generally speaking, rather overweight, obese, morbid obese type level. And they came to realise that being overweight was a negative influence on your ability to breathe properly. Then they started to realise that these people also had things like high blood pressure and diabetes and the consequences of those. And it had initially, before sleep apnea came onto the scene, just being attributed to the obesity. And as time has gone by, we've come to realise that there's this vicious circle where these conditions feed on each other, and then having obstructive sleep apnea mucks up your metabolism such that you can put on weight. Putting on weight compromises your airway. Having a compromised airway over time is not good for you, and chicken and the egg, but essentially it's all wrapping around on itself. So that was the history. And when it came to sleep studies, initially, as you'd expect, we had to use the technology that was available at the time. And at that stage, when things were happening, and this is even in my era of practice, they were using what were called thermistors. Now, therm hopefully gives it away. It relates to temperature. What they were doing is they were measuring the temperature changes of the air, because when you breathe in air, it's at room air level. When you breathe it out, it's warmed, so you can detect the change in the temperature of the air by putting a little sensor around the place. And they're called thermistors, and that allowed us to determine the temperature change, which then related to the breathing. It was pretty crude, but you had the best of what you got. We then progressed to what was called pressure transducers, where you could actually put a little measurement that actually measured the air flow and actually the strength of that airflow. And that gave us a little bit more information, because not only could we detect then who was stopping breathing, we could also detect a reduction in airflow. So not necessarily a complete obstruction, but a partial obstruction. And we called the complete obstructions apneas. Just breaking down the etymology of the word, a means without and nea means breath. So apnea means without breath. But we had this reduction in breathing, so we called that a hypopnea. Hypo means less and nea means breath, so it's less of a breath. And we decided, well, I didn't decide, we didn't decide, someone clever decided that a hypopnea at the time would be a reduction in airflow by a certain percentage. And then they decided, well, hang on, that's not enough. It needs to be sort of something a little bit more significant. So it was also and associated with a certain reduction in the blood oxygen level to match up the fact that the breathing problem was also tying in with the oxygen getting in and out of the system. And that sounds very sensible. As it's turned out, using these apneas and hypopneas as a gauge of measurement and drawing lines in the sand, what we've come to realise is that those measurements alone are really not telling us everything we need to do. Everything we need to know, but that's the history. So what we've got, and this is 30-ish years in the making, is a situation where we have got better at measuring breathing problems, made decisions early on based on car accidents predominantly at the time as to what was pathological in terms of having a breathing sleep problem and the fatigue that went with it. And then holding on to those historical facts and not really questioning what we were doing. The evolution of time meant that people identified a cohort of patients which were having trouble breathing at night, possibly snoring, having fatigue and tiredness affect them in terms of when they were waking up and then functioning during the day. And we went and did the sleep study, and it was perfectly normal based on the criteria that we were using and continue to use. So we had this line in the sand that was drawn based on stopping breathing, reduction in breath by a certain percentage, and oxygen drop associated with that, that then determined where the lines in the sand were for what was significant and what wasn't. But we had this group of people that just didn't fit into that box in terms of the test result. And because they didn't meet the criteria of the test itself, we had to create a new term. So we created a term called upper airways resistance syndrome. And if you like, this was sort of the box that we threw everyone else into that was complaining about the problems that other people had complained about, but were differentiated from those people in terms of whether the sleep study was normal or abnormal. Upper airways resistance syndrome had a normal sleep study. Then people got clever again and thought, well, we can do better than this, and decided that maybe there was a way of measuring trouble breathing at night, not necessarily associated with a complete obstruction or even a partial obstruction that met the criteria of concern. And that comes down to some physiology. So let me walk you through this. When you breathe, the diaphragm, when you breathe, diaphragm goes down. It's like a syringe, like a plunger system, pulling back. All right, so it's pulling the air in. Okay. What that is basic laws of physics and gas flow. Is that when you take a breath in, the pressure inside the lungs drops because the pressure inside the whole chest cavity drops. And this is where we got clever. People worked out that you could measure the pressure level within the chest cavity by putting a little probe into the chest by virtue of putting a little probe into the esophagus. Now, the esophagus is the food pipe that starts about here and runs down to your stomach, okay? And this pressure measurement is called esophageal, and manometry. So manometry means measuring the pressure level, essentially. Now, this is another point where people get very confused that I'm happy to clarify, because there's different types of esophageal manometry. So one of the places where it started was with gastroenterology people, so gut doctors and upper gut surgeons, looking at swallowing and being able to measure the pressure level through the esophagus to see if that esophagus was generating enough pressure, or whether it was a weak esophagus, and that meant that person had a swallowing problem, or whether the swallow was coordinated, or whether it was dysfunctional, a condition we called achalasia, but sidetrack. So esophageal manometry is a measurement of the pressure generated by the esophageal wall as it squeezes and swallows, but it can also be used as a measurement of the pressure level in the chest with breathing. Now, obviously, you need to know when people are swallowing so you can take that, what we call noise, out of the equation. But esophageal manometry, when we're measuring the pressure level in the esophagus, for this context, has got nothing to do with swallowing at all. Zero to do with swallowing. It's got everything to do with the chest pressure level. Because if we've got a little probe going and it goes down through the nose, down, sits around mid-chest level, okay, so mid-esophageal level, when you breathe in, okay, that negative pressure effect and then the lung expansion, that pressure is transmitted through into the esophagus, so you can measure the pressure level. So what we were able to do, finally, is that we could detect a situation where someone was making an effort to breathe, but the pressure that they were generating was much higher than it should have been to get that normal breath in. So basically, they were overcoming the obstruction by increased pressure level, okay? And this is where I need to start giving some analogies. I know I like my analogies, so this is the first one up. There's a few to come probably, but the first one. If you're at the gym, okay, and you're given a weight to lift up, okay, if you are not physically trained, not able to do it, and say it's 100 kilos, okay, you're going to struggle to do it. In fact, you probably won't be able to do it, okay? You just can't do it. But if you're generally physically fit and pretty good and done a bit of training maybe, you might have a chance of being able to lift that up off the ground. Similarly, upper airways resistance syndrome seems to manifest itself mostly in younger, healthier, fitter people, probably because they've got the partial obstruction, but they've got some physical fitness and conditioning on their side, which then allows them to, using that physical capability, overcome the obstruction to some point. Plus their cardiovascular system and respiratory system, if they're exercising, for example, is functioning better. So they have some, magic word, resilience, okay? And this is what the sort of thing comes down to, is having some resilience to balance things out. Because if you've got some resilience, then you can cope with things better than someone else that doesn't have resilience. And that approach, applies to lots of things in life, also applies to breathing. So we have these group of people that are, generally speaking, pretty young, healthy, fit, motivated people. They've got some form of airway obstruction that they are able to overcome. But if they have a normal sleep study without the esophageal manometry, everything will look normal. But the problem is we're looking in the wrong place. We're not looking at what their breathing effort is relative to their breathing success. So that's why esophageal manometry is a really important element now for more information, but it's not a standard thing that's done. So that's, upper airways resistance syndrome in a nutshell is a condition that we have created just by using words to define a condition that does not show up in a normal sleep study, but seems to affect people in ways that is very similar to those that we confirm as having obstructive sleep apnea based on the normal way we do sleep studies. So that's upper airways resistance syndrome. So the next, thing to progress from there is that, if this thing is somewhat poorly defined in terms of its boundaries, and the test that we normally would have to do comprehensively to find it is not normally done, where are these people? And the reality, these people are out left in the middle of nowhere, knowing that they're not well, knowing that things aren't right, but being told that everything is okay. And it clearly isn't. Those people with upper airways resistance syndrome have sleep problems, they have health problems, and they start to manifest rather interestingly and more significantly with mental health problems too. And it's probably partly frustration that they know they're not well, but everyone's telling them that, everything's normal, so get over it and get on with it. But also probably ties in with situations because, again, I'll use my sort of gym analogy. I'm going to swap analogies now for a moment. I'm going to talk about sunburn. If me, with my sort of skin, okay, pale as, very Celtic, very Scottish, goes out in the sun, and I go out in the sun with my mate from Sri Lanka, who, by virtue of biology, has more melanin in his skin, so he's got darker skin. I'm happy to say I'm white. He's happy to say he's got dark skin. We're not making things up. We both go out into the sun. He's absolutely fine. I basically get cooked to lobster red. And I'm therefore at much greater risk for the consequences of that, such as skin cancers. Okay, so especially with this solar panel, it's a real problem. So different people can be exposed to the same thing and have a different response to it, even though it's the same situation. And it's the same psychologically with upper airways resistance syndrome, is that if you have some other form of pre-existing issues with your mental health and well-being, whether it's depression, anxiety, sort of two big ones, but you might have some personality issues, you might have just some general stress in the background. Those sorts of things are disruptive to sleep at the best of times. And if you have some form of breathing problem, then you start to get this concoction that's coming together where people suffering from upper airways resistance syndrome, they're getting poor sleep, they've got some mental sort of stresses going on. They seem to be more distressed by their airway obstruction than people that, for example, have obstructive sleep apnea syndrome are. And it's a really interesting sort of spectrum of what we're seeing with respect to how these people turn up to the clinics. All right, so that's broadly the problem. Let's walk through the process of assessment in David World. In David World, this process of assessment would apply to kids, adults alike, regardless of the degree of airway obstruction that is being suggested. We are talking about upper airway obstruction. That means basically from here all the way up to there, okay? That is clearly ears, nose, throat territory, clearly, okay? And any clinical condition requires a history and an examination, okay? Investigations are necessary and appropriate, but they are guided by the history and they are guided by the examination. It's very, very unusual that you go to a test based on a history, okay? Examination is in between. So what examination would an ENT, that is an airway-focused ENT, do? Well, the answer to that is they would look inside the nose. They'll look outside the nose too, because sometimes the nose can collapse from the outside. Look perfectly fine on the inside, but sniff in and it collapses, okay? And then we're looking at the middle portion of the nose, which is the nasal septum. We're looking at the side wall of the nose called the turbinates. We're looking inside the nasal cavity for a build-up of swellings called polyps, which are tied in with sinus disease. And then we're looking in the space behind the nose, okay, called the postnasal space, or the nasopharynx, if you want to be fancy. And we're looking at what's called the adenoids to see what they are relative to the space that's available. We go down round the corner, but before that we'll talk about the mouth. So we're looking inside the mouth. First thing you see is the tongue, okay? Is it big or not relative to the space that's available? You look at the tonsils, you look at the palate, okay? And airway-focused ENTs will also start being very clever and start looking at jaw structure too. So not just like the outside of the nose, but we'll look at the outside configuration of the facial profile. And then we'll look inside the jaw and look at the top jaw to see if it's tight and narrow and sitting up or whether it's nice and broad. And then when we come down around the corner, we're looking at the back of the tongue, okay? What's called the lingual. Lingual means tongue, tonsils. So there's a set of tonsils people don't know about. It sits down in the throat at the base of the tongue. So that's the back of the tongue. So when you see your tongue inside your mouth, that's 1/3 of the whole tongue. The other 2/3 is sitting further down, and we can see that with our little telescope, goes down around the corner and we can see it. and we can see what the side walls of the throat are like. We can see what the voice box looks like, and then we can make a full anatomical appraisal of what's going on, and we can do some dynamic moves and measures as well to see what's happening, and that can help guide us then as to what anatomical obstructions are there that need to be managed. Now, I'm very holistic. I like to sort of think outside the square. So if people have skeletal jaw deficiencies, well, then we need a dentist, maybe a maxillofacial surgeon on board. And my immense work that I do with those specialties, it really highlights to me just how well attuned the dentistry profession, and I use that term broadly to cover therapists, hygienists, the whole gamut, are in tune with these things and mindful of these things. But I also think it's important that an ENT gets thrown in before dental treatments and things are thrown into the mix, because if there is more than one problem going on and the dentist finds that there's an airway problem and they see the dental part of it and focus on that, well, you may get a good dental outcome. That doesn't necessarily mean you're going to get a good breathing outcome, because if you've got two problems, then you need a team approach to it all. So that's just to highlight where I think teamwork is really important. And if we sort of think about how a team comes together, team has a captain. In David world, that captain should be the ENT. Should be the ENT that can look at the anatomical things and sort of say, all right, these are the anatomical things we need to deal with. All right, then there's a few other things going on here. Part of this sounds like it might be neurological, so we need to get those people that deal with that involved. We need to get our sleep physicians involved to clarify whether there is some other form of sleep issue going on here. It's not just obstruction. Whether there's an effect of things like insomnia and other sleep disorders going on. Get the myofunctional therapists on board, because we've got muscle tone problems and functional problems that result in that. So, it can be a broad spectrum team approach, but the ENT, in my mind, and I know I'm biased, so I'll beat you to that, should be the person driving the ship. They should be the one directing the traffic and sequencing things and planning things, but also, knowing that they need to do these things, knowing that they need to line these things up for the patients, so that there is a strategy and a plan that is tailor-made to each individual. So that's the sort of stuff, that the ENT is going to look for, and then we address it, And the big one, by far, is some form of nasal issue. Whether it's nasal allergies causing swelling, or whether it's some previous history of trauma that's causing a physical deformity of the septum, or maybe some nose and sinus problems with adenoids thrown into the mix as well, plus or minus tonsil problems, tongue problems. We can address all of those things when it's anatomical. And then, if there's some psychological issues, look, you've got to bring the psychologist in. Sleep can be dysfunctional because of mental annoyances, shall we say, and they can be managed and addressed by a psychologist where necessary. So, long story short, upper airways resistance syndrome is a condition that we have created for people that didn't fit into the traditional box of what sleep studies were diagnosing. As we've come to realise, sleep studies, in terms of the things that we're measuring, in particular apneas and hypopneas, don't seem to correlate very well with the types of illnesses that we're concerned about, such as high blood pressure, diabetes. And for the people that fall through the net or the gap and are suffering but get told that they have a normal sleep study, those people are really hard done by. And I would hope that anyone that thinks that they may be suffering from some form of breathing problem that is affecting their sleep will take on board what I've shared here today, and in particular, will take on the fact that seeing an ENT is really, really important, and you should be seeing an ENT that is airway focused. So that's it in a nutshell. I hope that is helpful for people out there. It's a difficult thing to talk about, as far as topics go, because it's very easy to point out the inadequacies of the topic itself, such as no clear, definite history that points in the direction of absolutes, no clear examination that makes it absolute, a specific types of investigation that needs to be done that is very rarely done, and then a nebulous approach to treatment, because it's a sort of, a lot of these people just fall into someone's hands, depending on sort of, who clicks and finds them first, as to then how they're managed. So again, I hope it's helpful, and please feel free to share this and all the other content that I throw your way. Cheers.